So good morning, everyone, and thank you so much for this invitation. We're both very happy to be here in Miami. Now, the title of this talk comes from my time in Oxford. For 6 years, I was the director for the fellowships in glaucoma, and each year I was allocated an Australian fellow. And often they come up to me and say, "Oh, g'day, Mr. Jutley, this one definitely needs a Trab." And we'd have a discussion as to why maybe Trab in this case wouldn't be indicated. And so that's where the talk emanates from. But it's not going to be a very light-hearted talk, I'm afraid. I'm going to take you to a dark place, a place where surgeons suffer anxiety, self-doubt, sleepless nights, and ruined holidays. So how are we going to do that? We're going to look at a case story, especially the surgical videos of the case. I'm going to give a literature view and also add in points that identify risk factors of the pathology that I'm going to allude to. I'll add my results from my time in Oxford and think about other alternatives to avoid the pitfalls that we will see. 57-year-old lady with open-angle glaucoma, asymmetric in nature, with a previous trabeculectomy in the left eye, flat bleb, failed on maximum medical therapy and progressing, was listed for a tube surgery. On the day of surgery, the operating surgeon, unbeknownst to him, penetrated with the traction suture, pulled the soft eye down. And then when we identified that, we reformed the chamber and continued. Post-operatively, reviewed the patient and then discharged her to be seen day one. So to discussion points, should we have continued and should we have admitted? Indeed, do people in the audience admit tube patients routinely to avoid Valsalva maneuvers? So on day one, here is why this talk is not a light-hearted talk, because we had a suprachoroidal hemorrhage. And this is just to herald the excellence of ultrasound, right? Because not only can you identify where the hemorrhage is, but also it plans your next step. If you see white, bad, leave it alone. If it's black, then it's liquefying, so you can enter and potentially drain it. And that usually happens after about 2 weeks. In this case, it happened sooner, so we went back into the eye. So I'm just going to run through some of the surgical technique. Essentially, you want to have an AC maintainer. You've already mapped out where the hemorrhage is, 4 millimeters from the limbus here. Go in with a non-valved trocar. And what you're going to see now is, sort of lovely bit of serous fluid coming out. I was always taught this is a glorified Chalasian surgery, whereby you're almost sort of scooping things out. So you're just going to express on the eye and get rid of it. Your best means, you've tried to wait for the clot to liquefy, but you find that little bits always remain. So enlarging the wound with the MVR, with the cyclodialysis spatula, put it in the suprachoroidal the choroidal space and get rid of all that heme. And yeah, it's just a glorified Chalasian surgery. So I've been attending congresses since 2008, I'd say, in ophthalmology. And every speaker ends with, well, day one, the patients saw 20/24 near, 20/24 in distance, everyone lived happily ever after, the so-called congress patient, right? My congress patient. So, ladies and gentlemen, that's the same eye. And the patient did 20/40 day one, and I was able to get good pressure control with a little bit of diode laser at the time that we left. So when I was told we're going to Miami, I was channeling my inner Will Smith from the 90s, thinking I'm going to Miami. And I thought, let me find a paper, a home paper from Bascom. And luckily, I saw this fantastic paper, which was coordinated here, but it involved a national cohort. And they looked at 3 months consecutively, 27,000 plus surgeries, and noted that a suprachoroidal hemorrhage was twice as likely post-tube than Trab. And that sort of correlated with papers by Tully and Jaganathan's team, which said that it was thrice as likely post-tube. The Tully paper also gave us further information. I just want to highlight 2 points from the paper. Number one, they identified other risk factors, including anticoagulant use and severe postoperative hypotony. And the second point, that if a hemorrhage were to transpire, the visual prognosis was rubbish. So bear that in mind regarding intervention, which we'll look at in a bit later. If you look at the wider literature, other risk factors exist, and I just want to focus those in red. A sudden drop in pressure. Well, why does it kind of explains why it happens more frequently post-tubes. Number one, we're listing patients for a tube surgery generally who have slightly higher pressure. So if you're entering an eye with a high pressure, you get this gradient of pressure reduction and you tend towards the hypotony. Second point, on the other side of the pond, we tend to reserve tubes other than secondary glaucomas for patients who failed trabeculectomy. So you effectively have 2 holes in the eye from the flap of the trab and the new one you create, again, veering towards hypotony. High myopia is interesting because I just want to share with you my results. Over a 5-year period as an attending Oxford, this is just in the public domain, we did this amount of filtration surgeries and we had a suprachoroidal hemorrhage rate of 1.35%. 4 were post-tubes, 1 was post-suture lysis, and unfortunately 3 were done by me. Emphasizing my point about the Congress patient who achieved 20/30 vision, the others sadly achieved no perception of light. The unifying factor in all of them, high myopes with long axial length. So we started looking in the literature, is there a length quantifying when the risk would be too high to do a tube, and would any modified technique be useful? There's not. We started just checking axial lengths anyway because of paranoia, but it kind of brings to the fore whether we have patients, colleagues in the audience who sort of would like to corroborate or sort of share data with a view to publishing this probably non-desirable paper. Now, we've talked about risk factors. We've talked about how I surgically managed this patient. Is there a general pathway, a consensus of how to manage the patients? And the answer is no. And from that eminent paper, most patients were just observed. And that makes sense, right? If the visual prognosis is so bad, is surgery really worth it? So to go back and form a rebuttal to the first point, this one definitely needs a trab. Now, we've seen in this section beautiful talks from sort of eminent ophthalmologists about options of different types of surgery. And I just wanted to throw my 2 cents worth in and say, if I've got a patient with fairly low drop burden and early disease, I would consider trabecular stents or a viscocanalostomy. If, on the other hand, I've got more drop burden, more advancing disease, I'd send my big hitter into BATS, which for me is a hydrous. Now, there is a caveat, of course, because it really depends on the level of the resistance. You could do the best nasal surgery in the world, but if your resistance is inferior, you're not getting the pressure reduction, right? So you have this mix and match approach whereby you could do a nasal hydrous and maybe an inferior omni at a second sitting, or a 360 procedure if need be. So again, there's no right answer. It's horses for courses. To conclude, beware myopes. That's my data, not in the published literature. And I can't emphasize the importance of considering all options prior to going into the OR. Thank you very much.